My section covers grandfathering questions and what is grandfathering, to what extent does it apply, and why would you want to keep it, and what do you need to do in order to keep it, and what happens if you lose it. The first few pages of the materials that you have take you through the specific provisions of changes that were made to the Public Health Act. They are in the sequence or the order of the sections of the PHSA that were either added or amended. And I've gone through and indicated effective dates for changes, for amendments or additional requirements as they relate to grandfathered plans and non-grandfathered plans. And there are different rules depending on whether or not we have a fully insured plan, a self-insured plan, and whether or not grandfather is elected. I hope you'll find these first few pages to be a helpful guide to you as you're looking at when compliance is required for different elements of PPACA. I'd like to take you then to slide number 12 on page 4, please. What does grandfathering provide? Why do we care? Why would you care? When you go through that grid of provisions that say grandfathered until lost, or you go through and find out, oh, there are delayed effective dates if we have a grandfathered plan, or that grandfathering doesn't make a difference at all, you have to come into compliance whether or not you have a grandfathered plan. I'm taking you through the 11 areas where it really does seem to make a difference as to whether or not grandfather is elected. The first one is that the plan is not required to cover all preventative care and wellness costs on a no cost share basis. So you're permitted to have co-payments or no coverage at all, whereas a grandfathered plan is going to be required to provide those on a no-cost basis. Co-payments can be imposed. There are limitations on the extent to which there can be co-payment requirements on participants. However, there is much more latitude permitted for grandfathered plans than non-grandfathered plans. Brian Bartels is going to get into the coverage for up through age 26 for dependent children. He'll discuss that in much greater detail, but there is a delayed effective date for the coverage of children on the age 26 requirement. There are certain reporting requirements that will apply to insured plans that insurers are going to have to make filings with the Department of Insurance and with Health and Human Services. And if we have a non-grandfathered self-insured plan, they will have to make filings with the Department of Health and Human Services. A grandfathered, fully insured plan, the insurer will have to make filings with the insurance department, but is exempted from the HHS requirement. For a self-funded plan, the employer would not be subject to any of the reporting requirements. In the next 3 bullets, you'll see that the word delay or delayed. Now, if you go back to the grid, and I'm not asking you to go back to the grid right now, you'll see that those are listed in my grid as grandfathered until lost. These 3 areas that I'm going to mention in just a section are already on the chopping block as to not, there is legislation that has been proposed that would remove these exemptions for grandfathered plans and just give them a delayed compliance date. So that's, and I have a feeling that these probably will be enacted. Under current law, there's no requirement for compliance for a grandfathered plan, but I suspect that we will end up with a delayed effective date such as 2014. So for fully insured grandfathered plans, there is an exemption from compliance with the non-discrimination rules for health insurance. If you had a plan, a discriminatory, fully insured health insurance plan in effect on March 23, 2010, that discriminatory plan can continue without adverse income tax consequences to usually the executives who are covered by that special health insurance arrangement. If you were to start a new insured plan today, it must comply with the non-discrimination rules of Code Section 105H. The next requirement is the internal and external appeals requirements are exempted for grandfathered plans, both insured and self-insured. There is a new claim and appeal process and a requirement that coverage must continue during the claim review time that applies to non-grandfathered plans, does not apply to grandfathered plans. So you could actually reduce or eliminate somebody's coverage while an appeal is pending under a grandfathered plan. The two remaining provisions that apply to grandfathered plans are exemptions. There is no need to provide emergency services at out-of-network facilities as if they were in network. Non-grandfathered plans will be required to cover emergency provided medical services as if they are in network. Grandfathered plans are not required to do that. And further, non-grandfathered plans are required to permit participants to designate pediatricians and gynecologists as primary care providers. Why does this make a difference? Because primary care will be covered normally 100% with no copay, no deductible. And in a grandfathered plan, those limitations could continue to apply, that only an internist or a dedicated primary care physician would qualify for that expanded coverage. So let's go back to our case study. Let's recall some of the facts about our particular employer. They have 300 full-time employees. That'll be covered in a little bit. But they have 30 full early retirees, all employees who have not attained age 65. This isn't technically grandfathering. This has to do with plans that have retiree-only coverage. This employer could break off those 30 retirees and create a plan that is exempt from PPACA 100%. Retiree-only plans are not subject to PPACA. It's due to a perhaps oversight on the part of the writers, but in the way that the law was written, retiree-only plans are exempted or are not covered by PPACA. So they could split off these 30 retirees and say, you're going to be under our old plan, and we're not going to bring it into compliance. So age 26 doesn't apply for dependents of retirees. Primary care never applies. Whether or not they lose their grandfather, they're just not covered by PPACA. This plan is fully insured. There is a $2 million lifetime maximum. That's effective January 1 of 2011. Lifetimes maximums go away, but the maximums do not apply. I'm sorry. The repeal of maximum limitations apply to grandfathered plans. That's one of the areas that is not exempt. There is on the annual maximums for certain covered services. Those are being repealed on a phase-in basis. For example, in 2011, the maximum limitation on an essential service such as prescriptions, you couldn't have an annual limitation of more than $750,000. In most cases, these limitations, annual limitations on essential services, are going to mean there is no limitation whatsoever. This plan has limited preventative benefit schedule. If it maintains its grandfathered status, it can continue that limited benefit schedule for preventative services. If it loses its grandfathering status, it's going to have to immediately provide that benefit, and that's the effect of losing grandfathering. You have to immediately bring your plan into compliance. They're thinking of changing their employee and employer contribution ratio. Under a grandfathered plan, to a limited extent, they would have that ability. Under a non-grandfathered plan, they could change that ratio. They have much more freedom to change that ratio, but they have only a limited ability to do that under grandfathering. They're considering changing the funding methodology from fully insured to self-insured. This is, as we go through in the next set of slides, how do you lose grandfather status? Assuming that this is not a collectively bargained plan, this would cause the plan to cease to be grandfathered. And they're considering dropping the coverage altogether. This is an area that Tony is going to discuss. So let's talk about what do they need to do in order to maintain their grandfathered coverage. Well, first of all, although it's not said in the facts, we have to assume that this plan was in effect on March 23, 2010, and that it had, and we know that it had people enrolled in it. It covered 300 full-time employees and 50 retirees. So it met the requirement of a grandfathered plan, assuming it was in effect on March 23. The plan must include a statement that it is intended to be a grandfathered plan in all documents provided to participants. Now, that clearly means in the summary plan description that's distributed. Our recommendation would be even to go further and say, put out a special notification that this plan is intended to be grandfathered. Put that up on your website. With 300 employees, they probably have a website. Send it out in hard copy, and maybe work with the insurer to see if they will include it with when they send out explanation of benefits, that there will be an insert with the EOB that this is intended to be a grandfathered plan. In order to maintain their grandfathered status, they must not increase the co-insurance percentage or any other percentage of cost sharing paid by the participants. So let's say that this plan provided that the employer pays 80% of the cost of coverage and the participant pays 20%. they could not change that percentage. If they would change that percentage to 70-30, grandfathering is immediately lost. And that's on a benefit-by-benefit basis, because maybe they had some coverages that are in-network, out-of-network, and there are different reimbursement ratios for those benefits, that if you're in-network, we'll pay 90%. If you're out-of-network, we'll pay 70%. They could not change those percentages. They could not eliminate or substantially restrict coverage of a particular diagnosis that they had provided previously. For example, let's say that they had provided free annual mammography. They could not reduce or eliminate that going forward and retain their grandfathered status. They may not increase the cost sharing other than through co-payments. This means that for prescription benefits, for example, let's say they had a $10 copay. They could raise that to $15. Doesn't affect the that does not affect grandfathering. They continue to be grandfathering. But let's say they said that the employee had a $50 out-of-pocket deductible for a primary care physician, and they want to change that to $100. That would not be permitted. And so there are some abilities to change these co-payment requirements, but they will be subject to a cost of living adjustment. They couldn't do the sort of change that I just described of going from $10 to $15. I'm sorry, on a $50 to $100 out of pocket, because that would be outside the guidelines of the permitted changes that they may make without costing them their grandfathered status. They may not decrease their contribution rate, and this means really the amount of money that they're contributing to for the cost of health benefits annually. They may not add an annual limit that was not in the plan on March 23, 2010. So we mentioned that they had some limits on particular services. The annual limit could not be changed significantly in future years. And as I mentioned, since it's a fully insured plan, unless this plan is maintained pursuant to collective bargaining, they can't change insurers. So if they're going to shop the marketplace for a new carrier on this fully insured plan, they have to understand that this means you're going to lose your grandfathered status. And if of course they change from fully insured to self-insured, they're going to lose their grandfathered status as well. So this is the kind of analysis that we go through with an employer and with a provider such as Silverstone, to ask the clients, well, how much do these grandfather benefits really mean to you? What are your savings by virtue of being a grandfathered plan, as compared with the flexibility you might have with a non-grandfathered plan and the ability to change carriers with a non-grandfathered plan? It's an economic analysis that needs to be done. And for those employers here who maintain retiree medical benefits for early retirees between the ages of whatever your retirement age is and 65, if you haven't done so, you really ought to consider whether or not you want to make that retiree-only plan, separate it out from your regular plan for your active employees, separate that plan out and exempt it from PPACA. And generally speaking, we're recommending doing that earlier than later. The reason earlier is more and more PPACA provisions are being added to these plans. Many are going to be added on January 1, 2011. If you carve out a retiree-only plan after that date, you're going to have to take quite a few benefits away from retirees. Not have to, but you may end up taking quite a few benefits away from retirees, and it'll look like a benefit cutback. Come 2014, when the pools are available, employers who maintain retiree-only plans, they may want to rethink whether or not they continue that retiree-only plan, because the pools are now available, and unless they're required to maintain those plans under some sort of a collective bargaining agreement, it's going to become a real economic question of whether or not they want to continue to do that. Next will be Brian Bartels, and he'll get into the age 26 requirements in detail.